The poster was, some of my earliest cases. It's like almost 300 cases. And this is when, I still think there was somewhat of a learning curve, not just with me, but with all of us with trabectome. And despite that, we saw pressure reduction. And this was patients with, multiple years follow-up. We only had about approximately 10% of patients required subsequent filtration surgery. So again, there's a lot of patients there, a lot of eyes that have avoided filtration surgery for at least a few years, if not longer, because of trabectome being in my armamentarium. I was impressed enough with my earlier results, and quite frankly, I think the results have become better since I've become more experienced in the.
How many surgeries have you done?
Several hundred, I would say. I'm not sure what the last count was, but I'm sure it could probably over 1,000 by now. 2007 was when I first adopted the technology. I think we're about the 25th, 26th unit in the U.S.
About how many surgeries would you say you do in a month?
Trabectomes?
Yeah.
It's like anything, you go through phases. I may perform, it could be anywhere from 5 to over 10. It just depends on the volume of pseudoexfoliation patients, some of these other secondaries that come, open angle glaucomas that come through. I've got a lot of advanced patients which still need filtration surgery, so I still perform probably a greater volume of filtration surgery than I do trabectome. However, there's a lot of patients, at least 5 a month, if not more, that I'm sparing from filtration surgery, and the majority of those don't ever go on to have filtration surgery once they've had trabectome. I think the key early on is getting positioning down. It's amazing how much further you have to rotate the head away from you and tilt the scope away from the patient than you would imagine. So I believe getting the positioning down, the view down, even before attempting your first trabectome is key. I've had patients before my first trabectome that had a very standard phacoemulsification, and I would just, at the patient's willingness to cooperate in my own identification, I would just go through the steps as if I was doing a trabectome, but I did not, obviously. Put the gonio lens on that we use for trabectome and just examine the angle, maybe even take Utrata or something just to kind of engage, looking, see my Utrata go through the gonioscope towards the trabecular meshwork. Spent very little time, obviously, and that was a good way to get myself comfortable before actually doing my first case. And first I was just doing on everybody. And my technique was, just a couple clock hours. I was still fairly much of a novice. You kind of go in thinking, okay, this filtration surgery is dead. I'm going to be doing this on everybody. And then you realize that it has its limitations. And so you do become somewhat dissatisfied. And so you start to back off. But then, with further persistence and there are still patients that, even when I was through this lull of not doing as many, there are patients it's perfect for, and I was finding such good results, such as pseudoexfoliation glaucoma, that I kept persisting. And then, actually when I heard of his results, it opened my eyes again to the procedure on the patients that were good indications. So I think patient selection became better to where a higher proportion of my patients were doing well following that transformation and seeing his data. I have become enthused again, as well as he has, to the procedure. Some technique modifications were helpful in re-engaging me. I think that Dr. Nils Lewin has really helped us as far as understanding that it is a delicate procedure, that we want to try to just pick off the trabecular meshwork and inner wall so that we don't harm the don't harm the collector channels downstream, trying to ablate as much as the angle as we can, try to vary your technique a bit to try to achieve 160, 180 degrees of meshwork if possible. I think that just, again, increases the availability of collector channels for direct outflow. I have had enough successes or enough patients that it's delayed their filtration surgery by multiple years, and I find that trabectome in my hands is the procedure of choice for like pigmentary patients, pseudoexfoliation patients, particularly if they have cataract. Even patients with really high pressures where you're thinking, boy, I need to do a trabeculectomy on its own or a tube on its own because their pressure is really high, where I simply just take out their cataract and do a fairly straightforward trabectome, that those patients do very well, and many of them for many years. And so I may hope, may permanently keep them away from a tube or trab, or at least delay it fairly significantly, in which case they're at least in a more controlled pressure setting where their pressures may be 25 as opposed to 45 before they have their filtration surgery.
Can you talk about your own personal philosophy when it comes to balancing the business of what you do with the commitment to your patients and really always trying to offer?
Yeah, that's a great question. I mean, I'm not only in my own practice, but in private practice, but also I'm in partnership with some other non-glaucoma specialists in our surgical center. And so, fortunately, we all have the same philosophy that, yes, that, the surgery center has to be profitable, or at least break even, but the main reason why we started is that we want to have all the control and use the best things. I mean, we don't quibble over if somebody wants to use a different widget or whatever that may be a little bit more expensive, but if that surgeon feels it gives them the better results, then that's what we're going to do. There's nothing worse than facing a patient after they've had a devastating complication from a surgery that you've performed, and so it's worth a lot of finances to any kind of personal financial gain to make the financial commitment to find other things that are better and going to be more efficacious and safer for the patients.